Good morning and welcome to the Intravitreal injection course. My name is Dr. Swindon Mamtora. Today we've got an amazing lineup and course timetable for you, and I'm sure you'll have a really good time. But to start with, I've prepared for you a collection of videos with interviews, animations and a tour of our department to show you how we run the AMD treatment service at the Great Western Hospital and how to use the Intravitreal device for delivering intravitreal injections. I hope you have a great day. Good morning and welcome to the Intravitreal course at the Great Western Hospital in Swindon. To start with, I'm going to be giving you a tour of our ophthalmology department. So here we are in the ophthalmology reception area, and here's the reception desk. Patients will come in and check in with the receptionist and make sure they're ready for their appointment. The next thing I'm going to be showing you is our coordinator's office. Their names are Amy and Rachel. Unfortunately, they can't be here today with us, but behind you is their office. Now, Amy and Rachel ensure that all the patients have their appointments booked for their injections, and as we use a protocol delivered service, they make sure that all the injections are delivered on time. One thing I can actually highlight to you is the fact that we scan in all the consent forms to Medisoft, and we use the Medisoft electronic medical record. By scanning in all the consent forms, this ensures that all the consent forms are always available on the day and at any time actually. And we were having some issues whereby the consent forms weren't always available on the day of injection because the notes weren't available for whatever reason if the patient had booked elsewhere in the hospital, and that's meant that we were spending a lot of time reconsenting patients. So I would recommend to other departments, potentially if they have the resources available, that they consider scanning in consent forms and scanning in documents wherever possible, and to use the Medisoft system as well as they can. For us as a department, we've found that that really helps us to generate really high quality data, and we've presented many posters, publications, and even published a number of papers in journals concerning our service as well, and the data that we've had from intravitreal injections. So, as we touched on briefly before, this is one of our main waiting areas. Okay, here we've got lots of information for patients, leaflets, and we've always got lots of services from our colleagues such as our ECLO as well, who can talk to our patients as well. Behind you here, we have our vision lanes, and we measure the vision using logMAR, 2 decimal places, for every patient, not just our medical retina patients, and this is using the Thomson visual acuity record screens. If needed, we can dilate our patients. We always usually dilate the patients with tropicamide and phenylephrine together. So I'm now going to show you some of our clinic rooms. And what you'll see when I take you through is that our clinic rooms are all in one. So we've got 6 clinic rooms in one larger room. And initially this might seem strange, but actually it's a really helpful thing because it means that working together with optometrists, registrars, junior doctors and consultants, anyone's able to ask for advice if they need it. This is actually one of our teaching rooms, and we've got a TV with a slit lamp camera, and that's used for teaching of junior doctors, medical students and nurses. And we've actually been running a program to do a rapid training and high quality training for our nurses and optometrists and other members of the team on how to perform slit lamp examination and other basic ophthalmic education skills. So here we can see many different clinic rooms within one large clinic room, and if anybody needs to ask for any advice, they can do so really easily. And I find that this is a very non-disruptive way to the clinic, and it means that everyone is really easily accessible as well. Okay. So I'm now going to take you through the journey of the patient, and if you can see on the floor we've got our yellow feet, and we're going to just follow the road and the map of the patient. So here we have our second waiting area B, and this might be where patients wait if they're seeing a doctor or clinician in rooms 4, 5 and 6. Okay. And we'll follow the yellow feet further down the corridor, and I'm now going to be showing you where we have our OCTs. In Swindon, we use the Zeiss Cirrus platform, and we have 2 OCTs in our OCT room. We've got one Cirrus 4000 currently, and we've got one Cirrus Photo 600. We're quite lucky that we've got quite an established virtual clinic service running, and patients are very positive about this experience. They say that they don't need to worry about waiting a long time for appointments, they don't necessarily need to be dilated, and they always find out the outcome of their results and scans afterwards by letter. If they have any concerns, they can always phone and ask to speak about this in more detail. The RCO and NICE guidelines recommends that all patients coming for virtual appointments have a 45-degree true colour fundus photograph, which can be undilated, and for this reason we use the Cirrus Photo 600 to take the colour photograph, and this can be used in conjunction with the OCT and the vision to determine if the patient needs any change to their treatment. Okay. So I really hope you found that video useful. and I hope you have a really great rest of your day. I'm going to be showing you some more photos now of Mr. Shah, some of our nurse injectors, and also the patient experience of when they're having their injection, how we do the injections with the Intravitreal device. So I hope you have a great rest of your day, and if you've got any questions, make sure you let us know. Thanks. Karen, thanks for joining us today to talk about the injections. I've just seen you give 2 injections of Lucentis to the patient we've just filmed, and the patient seemed to actually enjoy the experience. Well, I wouldn't go as far as say enjoy, but they seem to not mind it at all. How long have you been injecting for?
3 years.
Oh, that's quite a long time.
I've roughly done just over 2,000 injections.
Wow. And what do you inject with?
I inject with the Intravitreal.
Okay.
I would not inject into a patient's eye without it. It gives me the confidence to feel that I'm injecting in the correct place, that the patient's, with it being in the eye, is keeping the eye still.
Okay.
And having watched it done without an Intravitreal by doctors before I started becoming an injector, it's just cut above the rest really. It's 100% improved.
It seems to be quite a smooth process and very quick and efficient as well.
Yeah.
And I noticed that you're not using a drape when you're doing the Intravitreal.
No, because it's such a quick procedure. We started off initially draping everybody. The procedure took then another probably 10 minutes on top of what we were already doing. It upset the patients because they could see scissors cutting across her eye. It was making them more nervous, more anxious, which wasn't helping with the injection. And guidelines from around the hospital, infection control and everything, have said it doesn't need to be.
So the hospital infection control team have been quite supportive with that as well.
Yeah.
And I suppose in terms of claustrophobia and all those kind of things, it helps as well, doesn't it? Yeah.
The whole idea is to keep the patient as comfortable and not anxious as possible, because if they're anxious and they're tense, it's going to be an absolutely awful experience that they're not going to want to come back for.
Of course. And of course, most of these patients end up having multiple injections, many injections as well.
Every 8 weeks, every 4 weeks, whatever.
So you develop kind of a relationship with your patients as well.
Yeah.
Do you ever feel rushed when you're doing your injection sessions?
No. I think you can run these as smooth as possible. Obviously, the clinic that I do on a Friday, it doesn't run alongside an ARMD clinic, which means the patients come in and go. So my clinics run on time.
What if, like, a doctor asks you, can we squeeze in space for 1 or 2 more injections?
Oh,
as we always do.
Say yes.
And you never feel too rushed or stretched if that happens?
Sometimes I do go, I've done 19 now, enough is enough. But to be fair, when a lot of our patients are quite elderly, and it's quite an experience for them to not only get out of their house and come up here, to then turn around and say you've got to come back in a couple of days again to have an injection, which I could do there and then, I'll probably do it.
Sure. So what do you inject? So Lucentis,
the Lucentis and the Eylea.
Yeah. Okay. And how about your other colleagues, the other nursing colleagues who are doing injections? How many nursing colleagues do we have who do injections?
So we roughly have six nurse injectors. All run their own clinics each different days of the week. So we all regularly do a clinic the same day of the week. And then we step in when anybody's on holiday or on sick or what have you. So that sometimes we can make anything from 2 to 3 clinics a week.
Okay.
So
and does everybody all use Intravitreal?
Everybody.
Okay. And they've always used that from the start?
Yeah.
Okay. Tell us about the training process for learning how to do injections.
So initially it was watching, so you had to have a wanting to learn, if you like. Has to be it's quite an experience to inject into somebody. I think one of the things that I have is that I already cannulate and take blood, so I'm used to, and not many people do that in this department, but it gives you that knowing how needles feel when you're popping it into a body.
Manual dexterity, all these things.
So I had already had that experience under my belt. Some of the other injectors haven't, and it took them a bit longer to get used to but that is something that's quite good to have as a base. Then I just watched doctors for a little bit, and then they gradually introduced me into scrubbing, making sure I scrubbed correctly, putting gloves on correctly, and then I did quite a few clinics with Dr. Hassan, Dr. Ahmed, who watched, did it step by step. So first of all I started learning how to clean around the eye, then it went on to putting the Intravitreal in, to finally going to actually putting the injection in yourself.
So stepwise process.
So it's a step-by-step process, and you need to do that because you need to be comfortable doing each step before you go straight into doing it, because it is, ultimately at the end of the day, you want those patients to feel that the person who's doing it is competent. You're putting an injection into somebody's eye.
Yeah. So do you think you've got enough nurse injectors?
No.
So what's the plan?
So the plan is that we are currently looking for more people to step up into the role, and we are hoping after the summer holidays to start teaching a couple more.
How are you going to decide who's going to be trained?
Well, they've all sent me little written things as to why they
written
should
applications.
Be injected.
Okay.
And we'll do 2 first and then 2 after that.
That's great.
So I've got 4 that would like to have a go.
From your experience, how has the number of injections over the last few years changed?
I think when we initially started, the clinics were maybe 10 to 12 on a clinic. Now they're asking us to do 16 to 18. And I think the more confident and the more competent you become, the more happy you are to do a few more. The actual ARMD side of things has grown massively, to the point is that this is what's allowing patients to keep their sight, stay at home, and not have to drain on other social aspects like nursing homes or things like that. This is a really important procedure that we do, and I think it's brilliant.
Yeah, thanks a lot, Karen.
It's all right. This is our injection room that has been kitted out as a clean room. We've had a proper scrub sink put in to ensure that we're scrubbing correctly, and all of everything that we need for the injection is in here, so that we're not wandering in and out at any particular point to get what we need, so it remains clean the whole time that the patient's in here.
What about ventilation in the room?
We have air conditioning, so
That's great. So it's pretty much as sterile as we can be
so
then.
we've had the windows made frosted.
That's great, so that's good for patient privacy.
So patient privacy. Obviously we can't open any of the windows, hence why we have the air conditioning.
Perfect.
Because one, people smoke outside the window and it comes up, but two, we have to keep it as a sterile unit.
That's perfect. And when patients have had their injection, they can just leave straight into the clinical area then?
Yeah,
That's
and can
great.
go straight away.
That's
It's
great.
that quick a procedure, and it's not very invasive, and most patients get up and walk out straight away.
Yeah.
Very rare.
Do you use the Intravitreal device for all your patients?
All my patients.
Okay, that's great.
I wouldn't be doing this injection without it. Seriously.
So thank you very much, Mrs. Emery, for agreeing to be a part of our video today.
Very welcome.
Just to confirm, you're happy for us to film you today?
Yes.
And happy for us to distribute the video afterwards as well? Okay, so tell us a bit about how you ended up coming to the eye clinic in your first visit.
Well, I went for an eye test, and it was noticed by the optician who then referred me, and that was on a Saturday morning, and I was seen on the Sunday morning here,
Brilliant.
and then referred for ongoing eye injections.
Okay, and when was that?
That's a year ago.
Okay, and how many injections have you had so far?
8, I think.
Okay, do you know what injections you've been receiving?
Eyelia.
Eyelia, okay. And how's the experience been for you?
The first one was very nerve-wracking because it's a very unknown concept. Injections you think of in your arm and huge, but the experience, these girls are wonderful.
And tell us about the experience of injections for yourself.
I've had a couple of occasions where I've had floaters, black dots, which is pretty unpleasant, but after 24 hours it goes away. And then just forget about it till the next time 8 weeks later.
What about during the injection? How does that feel?
A couple of times I've felt it, I have to say, but mostly it just feels like pressure on the eye momentarily.
Okay, so no specific pain? No pain?
But I would say only twice I could honestly say I've really felt it, yeah.
Okay, that's fine. And what do you think about the setup that we've got here in Swindon?
Very good, absolutely
Okay.
superb, yeah.
Okay. And do you still feel nervous about coming for your injections?
Every time.
You still feel nervous? I suppose that's normal human nature, of course.
Yes. You
Okay.
think you get used to these things, but you never do.
Okay. And have you been told how many injections you're going to be having going forward, or?
Yes, I've just been told I'm going to have another year's worth of injections.
Another year's
because
worth.
it's not quite as it should be.
Okay. And which eye are you receiving treatment in?
The right eye.
Okay. And have you had any treatment to the left eye at all?
No.
Okay. That's fine.
Down to your feet and look up. That's it. Keep looking that point. Not to move your eye now. Stay very still there. Very still. Very still. And it's done. Well done. Close your eye.
I think the smile at the end said it all, really, didn't it?
Yeah, look up for me.
That was
please.
very
This
quick.
is anti-
Have a look for me. Very good. And down now. Close. Fantastic, thank you.
Alright, comfortable, not stinging. Yeah, lovely. So what we're going to do again is just clean around that eye with the iodine. So shut your eye gently again for me. And just go around the eye for a bit. Just into your lashes. Nice and clean.
So is that a Lucentis pre-filled syringe?
Yeah, this is the Lucentis pre-fill.
And do you think having pre-filled syringe helps?
I actually prefer the idea, which is not pre-filled.
Really?
Yeah, I do. Can I put it? That seems to draw out better, although it's a more viscous, it's thicker, the idea. I just quite like to draw enough.
You don't mind preparing your own solution?
No. I
Okay.
don't mind it that. It
Okay.
doesn't take that long, does it?
Yeah.
Okay, ready, Charlotte? So if you look down to your toes as far as you can go again. Lovely. So the Invitria goes under the top lid, pull out the bottom lid, and then get the patient to look at me, and then just release it. Okay, so back to breathing exercise is always good, because it makes them relax and think about other things. So you need to go in and out with your breathing now for me, Charlotte. In and out. All done. All right. Brilliant. You did really well. Take the Invitria out. And then we just check the vision. How many fingers? 2. So if you look over to Ashley, I'm just going to pop some antibiotic in there. And then show you eye corner. And just look over to Ashley again. Just pop these lubricant, nice and relaxed, calmly.
And which lubricant do you use there?
Celluvisc, 1%.
Whole
Okay.
ampule, we would give them a whole ampule.
And you give that to every patient?
They initially, when they first come, so on their first appointment, we tend to give them the lubricants to go home with. But after that, we give them what they need to buy.
Oh, right,
It can
okay.
become quite expensive, given out all the time, unless they're our favourite patients, which obviously safety is.
Of course. And what does our favourite patient think of the whole process?
Really straightforward. Yeah, and remarkable, really.
Yeah. You find it quite a relaxing process?
I don't quite say relaxing, but it's
That's great.
it's certainly
Yeah.
really straightforward and nothing to worry about.
That's great.
Well done, well done.
Thank you.
Well done,
Thank you very much.
Look up again. Face down gently. Okay, just because it was hurting a little bit more, I'm going to put some more anaesthetic in, okay? So again, if you can have a look up here. And look down, please. And up again. Fantastic. Close the eyes gently. Good. Okay, so just clean the eye out and put some iodine in. Okay, if you have a look up for me. Close the eye gently. Look down now. Close gently. Fantastic, thank you.
Okay, Charlotte, so I'm going to start with the right eye. So I'm going to begin by just cleaning around the eye with a cold solution. So if you just shut your eye gently, but don't scrunch it up too tight. Just going to come inside that. Under your lashes a minute. Okay. Well done. So just going to pop this little instrument in. So what I need you to do is look down to your toes as far as you can go. Keep looking down, now look at me. Lovely, just hold your eye nice and steady for me. Okay, so keep those shoulders nice and floppy. Keep looking where you're looking and keep that breathing going in and out for me. So in and out. There we are, all done. Just going to remove that for you. How does that feel? Great. Lovely. Now I need you to look at me. How many fingers do you see? Lovely. So I'm just going to pop some antibiotic drop in there. So if you look over to Ashley, I'm just going to just pop some eye in there. Can you shout for me? Now if you look over to your left again. Some lubricating drops just to make that nice and comfortable for you. Okay. How's that feeling? Is that alright? Lovely. So I'm just going to give the eye a little clean around just to get rid of the iodine.
So we're with Iris, who's one of our nurse injectors. Iris, thanks for joining us. How do you find injecting?
With injecting, I feel confident now with more practice and training.
And how long have you been injecting for?
I've been injecting for since 2017, so it's been 2 years now.
Okay, and in those 2 or 3 years you've been injecting, how many injections have you done?
I've done almost 3,000 injections.
Wow, that's an amazing number. Okay, tell us about your process and your journey for learning how to deliver injections.
So I've been trained by Mr. Hassan and Dr. Makaway, and I have to do 100 injections before they can sign me competencies. And we've got some examination as well with Mr. Shah.
What was the examination process?
It's more an anatomy of the eye and the measurement where to inject and like that. And
Okay. Was that quite a scary experience?
It is. It was a shaky experience.
The examination.
Yeah, everything is. Yeah, you know, it's. But if you're confident enough to do it, and you know, just don't be afraid to ask questions.
Yeah, I mean, I suppose taking any sort of exam taking any exam is always a cause for nervousness, especially if Mr. Shah is your examiner.
It is indeed.
Yeah. And just to finally ask you, what advice would you have for somebody who wants to start injections?
So they should be like confident to do it. They should embrace ophthalmology and know the anatomy of the eye. And what else? Just be confident and don't be afraid to ask questions if you're not sure with with the process.
Thanks, Iris. That's great. Thanks. I'm with Angela Exton, one of our most senior nurse injectors, who's performed nearly over 6,000 injections. Is that right?
Yes.
It's amazing. So, what I'd like to ask you is, how did you find learning how to do injections?
Okay. First of all, the opportunity to inject came across in the department, and I put my hands up to be trained as a nurse injector, and we were allocated sessions with a specialty doctor in the injection room so that we can be trained to, first of all, we watch the injections being done, and we have we sat down with the specialty doctor who did the anatomy and physiology of the eye with us, so that we understand what we're doing and the anatomy of the eye, etc. And feel comfortable when you're injecting, and how important it is to be injecting in the right place.
How long did it take for you to learn how to do injections?
2 months really, because I've been doing ARMD in my previous role, and I've always been doing ARMD, so I was really, when I put my hands up to do injections, I was ready for it because I've seen so many done already, so I find the process very, very easy.
And AMD has always been an area of interest for you.
It has.
What do you think it takes for someone to be an injector?
Well, you need someone who is calm and able to calm patients down and is passionate about what they do. When a patient comes into the room, they are very nervous. No matter how many injections they've had, it's always the first time for them. And when they see a new face, they get very anxious. So you have to be able to calm them down and answer questions, and my smiling face will calm them down.
What tips would you have for someone who's just starting injections?
To listen to what they have to say. Listening is very important because they're so nervous. Sometimes they are so nervous they are holding on to the bed frames when they come. So it's very important before they go into the injection room that you try and calm them down. Greeting them, having a little chat and trying to make them comfortable. And the nurse injector at that time would be noticing any signs of infection, or there are several things you're looking for in that little chat that you're talking to them. So it's very important to chat with them. And then you can also, at that time, you're looking at the eye, because you're going to inject that eye, and whether it's a droopy eye, whether it's, you're looking for signs of how you're going to inject in that eye, so that you make it easier for that patient when they go into that room.
So when you're talking to that patient, you're not just having a chat,
You're observing.
you're looking at them to judge, is this person an anxious person, is this person a nervous person? At the same time you're looking, does this patient have any mobility problems? Is the eye deep set? Are they going to be cooperative? How many injections have they had before? So you're making quite a detailed assessment for them, even just by having a basic conversation.
Absolutely.
Which also makes them feel more comfortable at the same time as well.
Absolutely. And they have questions to ask you, and if you answer it with the knowledge that you have, and you explain it in a way that they can, layman term we use, they understand it far better, because sometimes they have seen the doctor and they don't take it all in, and they come and they say, why am I having this injection today? I don't understand. And then you explain to them. We look at Medisoft and we see what the reasons are, and they always think that it's the only injection they're going to have. They never look ahead, am I going to have more? They always think this is the only injection I'm going to have. So it's very important to set their expectation that it may not be the last one, because there's a possibility it may well continue.
For a long time.
For a long time. So they have to be expecting that. So you set the patient's expectations so that but you said that this is the last one. Never say that, because you don't know yourself how long it's going to be. So that's between the patient and the consultant. We just set their expectation.
Okay. So Angela, you've done more injections than anybody else I know. What do you wish that you knew when you started that you know now?
What do I wish?
So what have you learned over the years? Those little tips and pearls about doing the injection that you wish you knew at the beginning.
A nurse injector, you have to have steady hands, and also a gentle touch, because patients always say when you're cleaning the eye, you've got a gentle touch. And they wish they can be in the couch a little bit longer for me to clean the eyes.
Really? It's like almost
It's
like a
like
massage.
it's like a spa, a mini eye spa.
So you
I
get
always
patients
say
to
to them,
feel really comfortable.
whilst doing the cleaning of the area, etc., and they feel comfortable. And when they finish the injection, he says, oh, are you finished? They're really shocked that it's all done, and they were so anxious before.
Yeah.
And I would say, you'll come again. Yes, I will.
That's really important, isn't it? Especially if
Yes.
the patient's got a prolonged course of injections.
Absolutely.
That they don't just stop attending for them. Not only is it important for their own health, but in terms of missed appointments and resources.
Absolutely.
Yeah. Well, thanks a lot for talking to us.
Thank you.
And I'm sure everyone's going to be spending a lot of time with you during the rest of the day anyway.
Thank you.
Alright.
Thank you.
So today we are with Amy and Rachel, the coordinators for the Macular Degeneration Service. Thank you, Rachel, for being with us. Thank you, Amy.
You're welcome.
So would like you to tell us for how long have you been doing the coordinator?
I've been doing the job for 5 years now.
Wow.
And I've been about 3.5 years.
Now, one of the things we have here at the Great Western Hospital is that we have a structured protocol for macular degeneration treatment.
Yeah.
For how long have you been organizing that?
It's about 3 years,
It's
I
about
think
3
now.
years now.
Yeah, 3 years.
What difference did that protocol give to your work?
It freed up quite a lot of slots in the A&D clinics, and I would say it did help. It does help, doesn't it, with the bookings?
Yeah,
and
definitely, and because patients know that they're coming back for clinic
yeah,
and an injection appointment, they know exactly where they are, what
Yeah.
they're coming up for.
I think we noticed that factor particularly when we asked patients for their feedback about the service. And by definition, macular degeneration patients are elderly patients. To arrange transport, to have a day off,
Yeah.
to have a day to come to the hospital, it's such a big job for them.
yeah.
So I think having the protocol also helps in
They
that
know
sense.
where they stand, don't
Yeah.
they?
We
with their
usually know
appointments.
surprises.
Yeah.
That is really nice. What have you noticed about the DNA rates? So you're like,
We don't really
We-
tend to get
no,
too many now.
Not too many DNAs, do we?
No, and a lot of the time if they know they can't attend, because they know what they're coming up for, they ring rather than just not
Yeah.
coming. So
that is really good. And what is the most challenging thing you find now in this service?
Well, I think in the whole service it has expanded, hasn't it? Like we do seem to be having a lot
Definitely.
more new patients coming
Yeah.
through, and it is quite a struggle, isn't it? To
and everything.
yeah,
We hope by training more nurse practitioners,
Yeah.
we will get more capacity and we will get more injections done, and that will
Yeah.
definitely help with the situation.
yeah.
So we wanted to take this opportunity to really thank you both for the great work you do, and we have good feedback from our patients, and thank you very much for the great work. Okay, so one more thing we wanted to hear from Amy and Rachel is that we have introduced a virtual service to review A&D patients. So please tell us what impact did that have on the workload?
Again, that has freed up a lot of clinic spaces, hasn't it, for
Yeah.
face-to-face appointments, having the virtual clinics for new patients.
And was there anything extra, or anything special, or anything that made setting up these clinics difficult, or do you think anyone can go ahead and set up any unit can set up their virtual clinics?
Yeah, I think so. As long as the virtuals get reviewed
Yeah.
in the
Yeah,
right
within the
time
time
frame.
scale,
But yeah, I think
We use basic technologies like having a scanner to have the patient's consent and paperwork. We use Medisoft, which is widely available.
yeah,
So I think all of those also helped
Yeah.
in the setup and the continuity of the service.
definitely. Yeah,
That is good.
yeah.
Thank you.
I'm with Mr. Hani Hassan, an ophthalmologist working at the Great Western Hospital in Swindon, who's going to be sharing his opinion on the use of Invitria for intravitreal injections. So Hani, thanks for joining us today
Thank you very much, Sunil, for
on the
having me.
Eurostar.
Of course, yes.
And tell us, what do you think about Invitria?
So I have been using Invitria to administer the intravitreal injections for the last 4 years. Straightforward, you notice that Invitria combines a few steps together. So you don't need to worry about putting a drape, you don't need to worry about putting a speculum or using calipers to measure the distance between the corneal nimbus and the site of injection. Using Invitria also makes it easy to stabilize the eyeball. So if someone is a little bit nervous or they tend to move their eyes around, you can stabilize the eye using the Invitria by applying gentle pressure. Again, by having the center of the cornea in the center of the Invitria, you make sure that you are always at a consistent distance of 3.5 millimeter from the limbus, and you are consistently injecting at an angle of 29 degrees, and consistently having about 2 to 3 millimeter of the needle inside the eyeball, and that reduces many risks like leading to the injury to the retina or creating traumatic retinal holes.
Do you think that there's a reduced risk of corneal abrasion by using Invitria?
It is something that is operator dependent. There is no data to say that using Invitria or avoiding using Invitria or any other intravitreal assisted device for that matter will reduce the rate of corneal abrasions. But the thing we all need to keep in mind, is that it's an operator dependent thing. Using the correct technique always helps to get consistent results.
Okay, and can you use Invitria with Osidex or Illuvian?
No. There are generally no assistant devices available for intravitreal implants. Nevertheless, though, I want to mention another point, which I find quite important, is with implants, because they are given through a larger hole or a larger gauge needle, you need to create your own self-sealing wound or self-sealing incision. While by using the Invitria, we also avoid this step, because when you have the eye stabilized, and we're going to show this in our demonstration during the course, you can simply twist the device gently, which will stretch the cornea, and then you give your injection, and then after that you release. So the cornea, the conjunctiva that has been displaced by this gentle rotation action will now come back and cover the injection site. And by that, you have a self-sealing incision, and you reduce the risk of any contamination of anything going into the eyeball.
What are your 3 top tips for someone who's considering wanting to start giving intravitreal injections?
Okay, now I think the most important thing is to insert and remove the Invitria gently and to follow the anatomy. The eyeball, by definition, is a ball, so it has a vault and then it tapers downwards. So when you insert the Invitria, follow this anatomy. Retract the upper lid gently, and that will create a recess into which you can advance the first tip of the Invitria, and then you can pull the lower lid down and put the other half, and that will keep it securely in place.
What's tip number 2?
And then tip number 2 would be making sure that the center of the cornea is exactly in the center of the Invitria, because by that, as I said, you will make sure that many parameters are accounted for. Tip number 3, which is something I learned after I've done a couple hundred injections when I first started, is that instead of using my fingers or a piece of gauze to retract the lids, I use a cotton bud, and by that I avoid touching the patient at all. So it's a completely non-touch technique.
Thank you very much, Annie.
Thank you, Sunil. It's always a pleasure.
And I hope that this will be a really productive course for everybody.
Thank you, and I wish all the candidates and all the attendees a very useful day today.